The evaluation of functional performance. This lecture is going to be specifically about assessment of older adults. Our objectives for this lecture are to differentiate among the various purposes and types of assessments and evaluations, describe the need for a conceptual framework to guide the assessment of functional performance, identify important areas of functional performance that should be assessed in older adults, and to describe factors specifically related to older adults that affect functional performance and need to be considered in an assessment. Need for assessment in later life. So why would an older adult maybe be referred to occupational therapy for an assessment? Definitely changes in health status, right? If an individual experiences any kind of injury, cognitive change, physical change, life status, mental status, they can be referred for an OT evaluation. An increasing prevalence of chronic diseases. So if someone has been living at home for a long time with some type of chronic disease, but now their status is changing, their functional abilities are changing, they can be referred to OT for an evaluation. It may lead to increasing difficulties in performing the daily activities of self-care, household maintenance, shopping and other community activities, voluntary or work pursuits, and recreation and leisure activities. Among United States adults, this is from the Administration on Aging, 19.9% of those 65 to 74 years old had difficulties with activities of daily living. Over half of those 85 years and older had difficulties with ADLs. Among adults over 65 living in the community, 27.3% had difficulty performing one or more ADLs, and 13% had difficulty with IADLs. Among those older adults living in institutions, 93.3% had difficulty with one or more ADLs, and 76.3% had difficulty with 3 or more ADLs. These are very striking statistics that show why it is so important for an OT to be a part of the interdisciplinary team for an older adult. Life expectancy and preclinical disability. So we covered a lot about life expectancy within the first lecture, but now thinking about more in an assessment frame of mind. Active life expectancy, which can be used to evaluate compression of morbidity, is defined as the average number of years an individual at a given age will survive and remain in an active or non-disabled state. The onset of disability can be slow and progressive, which often occurs with chronic disease, or sudden and acute, as occurs following a catastrophic medical event, such as a stroke, a heart attack, a traumatic brain injury, etc. The period between the onset of impairment and the onset of disability has been termed as a stage of preclinical disability, and let's talk more about that now. Preclinical disability is a transitional state between impairment and disability, which is characterized by a general decline in activity level or by limitation of ability to perform a task using the normal method, though the individual can still accomplish a task under certain circumstances without perceived difficulty. This predicts subsequent disability. Let's talk about the difference between a screening and a full evaluation. A screening can identify older adults who may need further evaluation or intervention, or both. It is important that screening evaluations be easy to do, take little time, and accurately identify those who require further evaluation for intervention. So I always tell my fieldwork students, my classroom students, how crucial it is to perform screenings as occupational therapists. There's a big difference between a screening and evaluation because a screening is quick, easy, can be done for a larger group of people because it's quickly done. So for example, when you do your fall prevention day in the fall semester, you're going to be doing fall risk screenings. So that way you can access a larger group of older adults at community centers. A full evaluation can take 45 minutes, an hour, or longer. Screenings, for example, when I was working on the stroke unit at Burke, I would have someone on my schedule to do a full evaluation with them at 7:30 a.m., meaning it was their ADL evaluation. I had to get them out of bed, get them dressed, get them to the bathroom, and see what their functioning was like. That made me anxious, right? Going in there kind of blind, you have the medical chart to review, but you're the first one as the OT to get them out of bed in acute rehab and being like, I don't even know where I'm going to start. And here I'm going to do a full evaluation on this person. What tools do I even need to pull? Do I need a sliding board? Do I need a shoehorn? Do I need a reacher? Do I need any specific papers with me? So instead of going there kind of blind, I would do a screening before I did my evaluation, whether that screening was the day before, if the person was there before I left for the day, if they've already been admitted, or early in the morning before I went in for my full evaluation. I'd kind of just pop my head in and say, hi, good morning, or hi, good afternoon. If I'm seeing them the day before, my name is Danielle. I'm going to be an occupational therapist doing your evaluation. I just wanted to come and introduce myself and get an idea of what your movement is like. Is that okay with you? Get their permission. And in this quick screening, I'm not getting them out of bed. I'm not doing anything that would take too much skill for a quick 10-minute screening. I'm kind of just saying, can you lift your arms up for me? Can you kick your legs? Can you touch your shoulder? Giving them quick little movements to do. And also, if they're verbally responding to me, that's telling me about their ability, their speech abilities, their cognitive abilities, just so I have an idea of what I need for their full evaluation. Meaning not only tools that I might need that I gave examples of, but also if I need another therapist with me. You know, in the subacute rehab at United Hebrew, we did co-treatments for evaluations very often if someone needed two skilled therapists. Sometimes it doesn't need to be a second skilled therapist. It could be a rehab aide, but I need to know I need that person before walking in there for their full evaluation. Now let's talk about different types of evaluations. So a descriptive evaluation focuses on gathering information to describe characteristics of individuals and enable differentiation between persons on the specific characteristics that is being measured. It identifies issues that may merit intervention to determine specific problems in the areas of impairment, activity limitation, and participation restriction, and to help determine the need for therapeutic services. I'm sure you learned about these already in your assessment and evaluation class, so this should be a review. A predictive assessment includes items related to a specific characteristic in order to forecast another trait. Items on a predictive measure are included if they describe the characteristic of interest and predict the trait or criterion of the interest now or in the future. An outcome evaluation is to ascertain how a particular intervention has affected the individual. So matching your question with the assessment. Therapists need to be clear about the goal of a particular assessment. They must understand the qualities of the specific instrument to determine whether it is useful for the needed purpose. Therapists should have a conceptual model like the ICF or PEO, the Person Environment Occupation model, that they're using as their frame of reference or their guiding theory. So when you're talking about matching an assessment to your question, what are we considering? We're thinking about if the assessment is performance-based, meaning you're actually watching someone perform an occupation, an activity, versus patient-reported outcomes. Or is the patient just telling you how they're functioning? Is it an interview? Might even be an interview with their caregiver. Is that going to access the information that you want? Is it standardized versus a functional assessment within the patient's home and non-standardized? Is it complex or simple? Global or multidimensional? generic versus diagnosis specific. You'll see many different scales specifically for an individual with stroke or specifically for an individual with a traumatic brain injury or spinal cord injury. How much time does it take to implement the scale? Is there any training or certification that's needed to be able to use the assessment? Does it cost anything? Is it computer administration and scoring, or is it paper and pencil tasks? Is it fixed versus computer adapted testing from a pool of items? These are all things that you're going to want to consider. This afternoon in class, you're going to be working on creating cheat sheets for assessment tools that I'll explain later on in more detail. But those cheat sheets, these items should be on there. Definitely things like how much time it takes to perform. Is it performance-based? What materials do you need? Do you need a certification in order to use this assessment tool? These are all things that should go on that cheat sheet. More considerations for choosing assessment tools, the psychometric properties. So reliability is the degree to which test scores are free from errors of measurement. For example, the extent to which an instrument yields consistent results with repeated implementation. That's called test-retest reliability. There are also other forms of reliability, such as inter-rater reliability. Validity, how well an instrument measures what it purports to measure. For example, predictive validity or evidence of a statistical relationship with a criterion. And responsiveness, the ability of a scale to actually detect change. Here are a few resources that you can access, mostly for free, many of the assessment tools for older adults. It's very interesting. Pediatrics, a lot of the assessment tools cost a lot of money and come with these large kits. Same thing for mental health. I'm sure you've seen those in both your courses. But in the older adult world, and physical disability world, a lot of the assessment tools are free and easily accessed online. So definitely take a look at these websites. For a comprehensive geriatric assessment, you need to look at the full picture. We're holistic therapists. So we'll definitely be looking at someone's mental status. And there are a few examples of the assessments that we can use to look at mental status. Their emotional status, their ability to communicate, mobility, balance, bowel function, bladder function, nutrition, daily activities, and their social situation. When you're working on an interdisciplinary team, some of these different areas of assessment might be designated to other professions. For example, bowel function might be designated to nursing within a hospital setting or a rehab setting. However, if you're working in home care, you might be the therapist or the professional to cover bowel function. Same thing for mobility. It's always, an interesting conversation with physical therapists. I've actually had many that have said to me, no, physical therapists cover mobility. And I always clarify and say, well, occupational therapists cover functional mobility. So you might be able to see them walk down the hallway 20 feet with moderate assistance, but I need to know how they actually get onto the toilet. How do they walk from their bed to their toilet? How much assistance do they need? It's very different walking in a straight line or walking in a straight hallway, making one turn versus negotiating things that might be in their room, like their bedside table or a cane that fell down or a tissue on the floor, and then walking through a doorway to their bathroom, turning around, doing all their hygiene management, their clothing management, and sitting on the toilet. That's very different than what a physical therapist is looking at. Some more areas that may require evaluation, the person's exercise capacity and tolerance, functional mobility, like I was saying, a person's usual or actual performance of mobility, overall functioning and disability, performance difficulties in self-care, productivity, and leisure activities, roles that are important sources of activity for older adults, ADLs and IADLs, multiple domains of physical functioning using observed performance of tasks. That's what I was saying before. Is it a performance-based evaluation you're looking at? Home safety and cognition. Now we're going to cover specific issues that you need to think about when assessing older adults. So when working with older adults, there are other factors that may come into play that may not be the specific reason why you're seeing that person in the first place. For example, sensory changes. To ensure an assessment occurs under optimal conditions, you must make sure that the lighting is adequate in the environment. All materials are presented to the person, especially written materials, are in print that is large and a contrasting color with the background so that they can easily be read. The environment should have minimal background noise to enable the client to focus on the evaluation and any interaction with the assessor. The assessor should face the client. Verbal communication should be clear, allowing the older adult to hear what is said optimally, and at the same time, see if the assessor's face to pick up any nonverbal communication as well. The older adult is using any prescribed aids, such as glasses or hearing aids. That's always one of my first questions before I begin an assessment. Do you have everything you'll need here? Do you typically wear corrective lenses? Do you typically wear a hearing aid? Is there anything else that you typically use during your daily functioning that you might need? If the person's not able to tell you those things, you should absolutely be looking in their medical chart or any approved caregivers that you're allowed to communicate with. I do have an example of this when I was early on in my career as an OT. I was performing actually a movement assessment for tone on someone, for muscle tone on someone in the therapy gym. It was an older adult. He was there for a stroke. We were in the therapy gym and I was trying to assess his tone, and he wasn't really following my directions. I just kept going. I kept going with my assessment. And then his daughter came up to me and said, I don't think he can even hear what you're saying because there is so much going on in this gym. There's, a patient over here, a patient over here. People are talking over each other. Can we go to a separate room? And to tell you, I turned bright red and started sweating. And I said, You're 100% right. Absolutely, we could go to a different room because I wasn't testing his ability to hear me or his ability to only follow those commands. What I was trying to measure was his muscle tone at that time. And it was an unfair disadvantage for him to be at if he couldn't even hear my commands. And once we went to a different room, sure enough, his performance improved. So that was a huge learning curve for me. And to see, wow, I don't need to stay in the clinic. We could go to his hospital room and we could perform it there much better. So never be afraid to correct yourself. We all make mistakes. Hopefully none of them actually hurt or cause any harm to someone. But something like that, where it's like you can admit you're wrong and say, you know what? 100%. Let's change the environment. Let's change where we're sitting. Let's change the lighting, see how they might perform differently. Fatigue, it's a self-perceived concept. It manifests as an older person's lack of participation in physical functioning activities, such as walking or activities of daily living. So you really need to consider this when you're picking an assessment and how long it might take a person to complete. If an assessment's going to take a person 2 hours, you should be looking at that assessment manual and seeing, am I allowed to break this assessment up into multiple sessions? Right? So maybe I perform half of it this morning, half of it in the afternoon, or throughout multiple days. Or maybe I can just pick a part of the assessment to perform. If the assessment is standardized, most likely the answer will be that no, you can't make those adjustments to it. However, if an assessment is not standardized, then you can start to make some adjustments and just qualify that within your documentation. A client experiencing fatigue may struggle to participate in functional assessments of mobility, activities of daily living, and lower or upper extremity function. And sometimes it does cut to a point where you're performing a standardized assessment with an older adult. You see they're becoming extremely fatigued and it's not safe to continue, or you need to give them a break that's not in the standardized method of doing the assessment. And then you just write that in your documentation, you qualify it. And you could say, even though this assessment is standardized, it was performed in a non-standardized manner due to the client experiencing fatigue, after 30 minutes performing this specific task. Cognition. People with mild cognitive impairments may also have difficulties completing activities such as IADLs that have higher cognitive demand, such as banking or managing medications. Limitations in functional abilities do not necessarily mean that an older adult has a concomitant cognitive impairment. It is so important that when you are performing an assessment, you know why the person might be presenting in a specific way. What I mean by this is if you're measuring physical performance, however, they also have a cognitive impairment, you need to be sure that their physical performance is accurate and it's not the cognitive impairments impeding their physical performance that you're seeing. And if you're not able to separate the two, always writing that in your documentation, not just putting a score down. Oh, they got a 5 out of 30, which means that they're at an extremely high fall risk, or, that they are definitely going to have this level of endurance. If that was impacted by their cognition, you could put their score down, but say, the client might not have understood the instructions to the task as evident by, and give examples. Education and caregiver support. It's so important that assessments are appropriate for the individual that you are treating and their level of education. So to understand what their reading comprehension level. Very often, if someone is within the medical model system and they have a social worker or a medical manager, there will be some documentation of what their level of education is that can give you some idea of their reading comprehension. If someone's in a community center, you might have to do a screen before you pick the assessment for them, like I was saying earlier, to get an idea of their reading comprehension. And caregiver support. Both need for support and level of available support must be considered. So always getting an idea of, do they live with anybody at home? Was anyone helping them with any tasks previously? Very often I hear older adults say, I was completely independent. I lived in my house on my own. I didn't need any help. But then when I start to dissect things a little bit more and I say, were you managing your own medications at home? They might say, oh, no. One of my kids come and they set my medications up for the week, and then I take them when I'm supposed to during the week from a pill organizer box. Okay, so they're not completely independent. Or, oh, so were you cooking all your own meals at home? Oh, no. I have a meal service that drops off my meals for me. So not just getting that general statement about how their functioning is, but really looking at the specific activities and occupations that they'll need to perform once they're discharged home. Cultural congruence. So the client's cultural background can directly influence, of course, health perceptions, health behaviors, and acceptance of therapeutic regimens. All persons tend to demonstrate greater adherence to directives that are congruent with their own cultural health beliefs, right? If something fits within your way of living and your habits and routines prior to having any kind of health concerns or changes in status, then you're more likely to adhere to what the therapist is saying that you should do. The OT asks the client to identify his or her own occupational concerns and goals to design an intervention that recognizes how the client's cultural values influence his or her response to the compromised occupations and life satisfaction. The activity you'll be performing within your class time is the assessment summary sheets. Okay, so I started to mention this before, and this was a trick that I used when I was in school. I've told all my students since to use this trick, is to save all of your assessments in different binders or different full physical binders if you're like me and you like things that you could actually tangibly touch, or everything is now computerized, right? Creating folders on your computer to have a definite organized manner of having your assessments easily accessible for you. So some people choose to have that as, I have a folder for pediatrics, for older adults, for physical disabilities, for mental health. Or you can have it as, I have a folder for ADLs, IADLs, cognition, and those could even be within older adults itself. Okay, so you have to pick what method works best for you in your organization of the assessments that you've been collecting. This will be extremely helpful when you study for your boards, as well as when you're on fieldwork too, as well as when you're a clinician. I still, to this day, go back to my assessment binders and look at what I have in there just to get different ideas of some assessments that I might not use often, but now I have a patient that's appropriate for it. When I was on fieldwork too, my supervisor said to me, I want you to perform a cooking assessment with this person tomorrow. I knew exactly where to go in my binder under older adults, older adults, IADLs, and there was my kitchen assessment task evaluation. Pulled it right out. I had my cheat sheet there, so I was able to quickly review how long the assessment would take. Did it cost any money to perform? Did I need a certification? Is it standardized or non-standardized? I had all that information easily accessible to me right there. So it took me all of 5 minutes to pick which assessment I would use. And then I was able to actually prepare and to practice administering the assessment before I did it with a real live patient. So today you're going to be organizing assessment sheets for different older adult assessments. Okay, so the first step of this is thinking about as a class, what needs to be included in the assessment sheets. And I've already given you a lot of hints of things that you should be including. But don't forget even basic things like the titles, the format, meaning is it an interview, a questionnaire, performance-based, etc. What population is it intended for? What's the purpose of the assessment sheet, etc. I don't want to give you all the information. I want you to take the rest of the time you have during this asynchronous period and really write out a list of what do you think should be included on an assessment summary sheet. And then as a class, you're going to come up with one template that you would all use. You can share it on, you all have your methods, Google Docs, or just email it to each other. And all the groups should be using the same template for the different assessments. So here is the group work. These are how you'll know which assessments your group is focusing on. Okay, and you're all going to fill out that same template. So you have the information for all of these assessments in one place. Okay, it's up to you as a class how you share this information, whether you want it on your shared Google Docs or if you want me to create I will create a discussion board so you can put all of the assessments there as well. So you can refer back to them and nothing is lost. But these are definitely cheat sheets that you should save for the future. They will help you immensely, I promise. We'll continue to go over assessments throughout this course. New assessments will come up. You might discover an assessment that is brand new that we haven't even used yet, based on what your client might need, and dissect them and really see how important it is to truly understand the assessments we're using with older adults. Thank you.